So, good evening, everybody. We'll be discussing about grade system of assessment and European Stroke Organization acute stroke TPA guidelines, which have been recently issued. So, these guidelines are very important for us for next coming years because the previous guidelines were issued in 2012. So we all know that intravenous thrombolysis is the only approved systemic reperfusion treatment for patients with acute ischemic stroke. These European Stroke Organization guidelines provide evidence-based recommendations to assist physicians in their clinical decisions regarding intravenous thrombolysis for acute ischemic stroke. As I said earlier, the previous set was issued in 2012. The ESO working group identified relevant clinical questions, performed systematic reviews and meta-analysis of the literature, assessed the quality of the available evidence, and wrote recommendations. The expert consensus statements were provided if there is no enough evidence to provide recommendations based on grade approach. So there are two issues here. One is an expert consensus statement when there is no uh, evidence available. The group identified relevant outcomes by Delphi method to score their importance. That is, a mean score from 10 respondents on a scale from 1 to 10 is used. Functional outcome including death, that is MRS score of 8.3 is the most important outcome they thought of assessing in all the studies where alteplase was used to treat acute ischemic stroke. The second important outcome which they were covered was symptomatic ICH 7.6, death 7.4, quality of life 6.2, imaging measured recanalization 5.9, major extracranial bleeding 5.7, neurological outcome, that is NIH stroke scale 5.5, and imaging measured final infarct volume, that is 4.7. So these are the relevant outcomes that were addressed. The ESO module working group, as it is known as MWG, formulated a list of population, intervention, comparator, outcome, that PICO questions. And the main recommendations were based on a systematic review of RCTs of IVT versus control. Whenever there is no RCT available on a certain topic, each PICO group conducted a literature search to identify systematic reviews of non-randomized studies or key observational studies. So whenever appropriate, the random effects meta-analysis was conducted using Stata software version of 11.0, that is Stata Corp. Results were summarized as odds ratios. ORs are common odds ratios and their 95% confidence intervals. The heterogeneity in the studies across studies was assessed using the I-square statistic, and it is classified if it is 30% as moderate, 50% as substantial, and considerable is 75%. That is the heterogeneity of the studies. For each PICO question and each outcome, the risk of bias was assessed, and the quality of evidence was rated as high, moderate, low, or very low based on the type of available evidence, whether it is a randomized evidence or an observational study. And considerations on inconsistency of the results, indirectness of evidence, imprecision of results, and the risk of bias were taken into consideration. All these factors are factored into giving a weightage to the evidence. And importantly, each PICO group addressed their respective PICO questions. Analysis of current evidence of RCTs is done for the for answering each PICO question. If there is no RCT, the systematic reviews of non-randomized studies and an evidence-based recommendation are provided based on grade methodology. The direction, the strength, and the formulation of the recommendations were determined according to the grade evidence profiles and the ESO standard operating procedure. One of the important things to understand is the guidelines are given with a bracket where evidence is written, whether it is a low evidence or a high quality evidence. So we have to apply these recommendations keeping in view the weightage given to the evidence. When there is not possible to assess from the literature, then the experts issued a consensus statement. That means there is insufficient evidence. A consensus statement is provided, which is a pragmatic suggestion, which is of course not evidence based, right? It is provided. So look at the systematic and meta-analysis, how the knowledge is translated from clinical research to practice decisions mostly. Clinical trials and observational studies, they generate evidence, and systematic reviews, this is called evidence synthesis. Example, Cochrane collaboration and others. And professional societies and others, they form the clinical policy or guidelines which we are going to study today. And in the end, the evidence-based healthcare is imparted by application of these guidelines, application of policy. That is, the three factors are here: evidence, clinical expertise, and patient values, which are the key components of evidence-based medicine. In the hierarchy of evidence for intervention studies, that means when you are talking about treatment, prevention, screening, and harm, the top of the pyramid is occupied by RCTs and systematic reviews of RCTs, SRs of RCTs, or meta-analysis of RCTs. Below that, even one single randomized trial is there, we can have a good evidence. Below that is systematic review of observational studies addressing a patient important outcome, not surrogate outcomes. Then single observational study addressing patient important outcome, not surrogate outcome, not a lab value. Then the physiological studies and unsystematic clinical observations. So all these things, this is the pyramid of hierarchy of evidences. The grading of recommendations, assessment, development, evaluation is a system, is arguably the most widely used method for appraising studies to be included in systematic reviews and guidelines. So based on this system, each study is subjected to 5 important components, which I am going to tell. It is emerging as the most dominant method for appraising controlled studies and also making recommendations for systematic reviews and guidelines. Anyone reading a systematic review or evaluating guideline recommendations, they need to understand what is grade in order to apprise the review or guideline. So unless you know what is a grade system, it's very difficult for us to interpret what they are saying. So this is very important for us. Grade is a method used by systematic reviewers and guideline developers to assess the quality of evidence and decide whether to recommend an intervention or not. So we have studied some outcomes and which they are going to be incorporated in the guidelines, which we are going to study now. The grade separates quality of evidence and strength of recommendations. For each outcome in the study, the quality of evidence is assessed first. Even observational studies can be upgraded if they meet certain criteria. It's not required that only RCTs are there. Whatever evidence is available, we can apprise it and we can take cognizance of that. The grade methodology essentially uses 5 steps. That is very important for you people to know that there are 5 steps in grade methodology. The first is assign an a priori ranking of high to randomized controlled trials and low to observational studies. That is, RCT is less prone to bias, Islam. So you give high ranking to that. Now, downgrade or upgrade the initial ranking which you have given by following the other steps. Assign final grade for the quality of evidence of the study as high, moderate, low, or very low for all the critically important outcomes. Consider other factors that impact on the strength of the recommendation for a course of action. Make a strong or weak recommendation. So, whatever is given in the guideline, you see there is a quality of evidence which is graded as low or high, and a recommendation which is given as strong or weak recommendation. So when you apply the guideline interventions to the patients, you should keep this in mind. The grade step, uh, downgrade or upgrade the initial ranking which you have given, and the randomized controlled trials and observational studies can be used to be downgraded because they suffer from identifiable biases which we will study. Secondly, even observational studies can be upgraded when multiple high quality studies show consistent results. So then also observational studies can be used to upgrade an evidence. So let us look at the reasons to downgrade grade an evidence. The first reason is risk of bias in the studies. Lack of clearly randomized allocation sequence if the study doesn't show, lack of blinding, lack of allocation concealment. There is a failure to adhere to intention to treat analysis. The trial is cut short and it didn't complete. There are large losses to follow up. If all these six factors are there, then we can say that even though it's an RCT, it has got a risk of bias. Second one is inconsistency. When there is significant and unexplained variability in results from different trials, we call that inconsistency. The third thing is indirectness of evidence. Indirect comparison of two drugs. If there are no trials comparing drugs A and B directly, we infer a comparison based on separate trials comparing A drug with placebo and drug B with placebo. The study population in the two trials may be different also. An indirect comparison of population outcome intervention, that is comparative stockings for trauma patients. When you use a compressive stockings for trauma patients, this was downgraded because the study was conducted in general population, not a specific population. So this is one of the examples of indirect comparison. Imprecision, when wide confidence intervals mar the quality of the data, then we call it as imprecision. Publication bias, when studies with negative findings remain unpublished, and systematic review of all published positive studies will give a biased result. So we have seen 5 reasons for a study to be downgraded or upgraded, and reasons to upgrade is large effect. When effect size is so large that bias is common to observational studies and cannot possibly account for the result. See, we see that the oral anticoagulants decrease thromboembolic complications by about 80%. It doesn't require a randomized controlled trial because the effect size is so big. Dose response relationship, nurses' health study. More physically active the nurses were, the smaller the risk of stroke. So this is a common sense. You don't require RCT for such type. That means whatever available literature evidence is there, we can upgrade it. All plausible biases only reducing an apparent treatment effect, so not real. So now we have seen that whatever literature we have set for forming the guidelines, the RCTs, the observational studies, we assign final grade for the quality of evidence in these studies as high, moderate, low, or very low for all critically important outcomes. A rule of thumb is to move up or down one category per issue. Why we should study this is very important, because each recommendation in this guideline is qualified by these. So without knowing the quality of evidence on which you are basing your treatment recommendations, you may do harm to the patient. Or patients may ask, when you are not sure, why are you giving this? So, in this, if there is a high grade evidence, that means we are very confident that the effect in the study reflects the actual effect and we can give the treatment. Moderate means we are quite confident that the effect in the study is close to the true effect. It's very close to the true effect, but it is also possible it is substantially different. So again, there is a suspicion statement. Low means the true effect may differ significantly from the estimate. Very low means the true effect is likely to be substantially different from the estimated effect. So when we go through the guidelines, you will realize that how many recommendations that are mentioned in the guidelines, if you don't read this fine print, you may not be doing justice to your patient. Step 4, consider other factors that impact on the strength of recommendation for a course of action. High quality evidence does not always imply a strong recommendation. Recommendations must consider factors besides the quality of the evidence. The first factor to consider is a balance between desirable and undesirable effects. If okay, study has an aim, it has reached its effect, but whether it is required for us or do you have to see and then only give a recommendation. So last step is make a strong or a weak recommendation in grade system. When the net benefit of treatment is clear, patient values and circumstances are unlikely to affect the decision to take a treatment, and a strong recommendation is appropriate. High dose chemotherapy for testicular cancer is recommended for the increased likelihood of survival in spite of chemotherapy's toxicity, because testicular carcinoma has got a very good response. If the evidence is weak or the balance of the positive and negative effects is vague, a weak recommendation is appropriate. So let's look at the final the grade tree. Step 1, a priori ranking. Whether it's randomized control trial, you make it high ranking. Observational study, you put it in an a priori before starting the allotment of the grade. Step 2, upgrade or downgrade depending on downgrade, risk of bias, inconsistency, indirectness, imprecision, publication date bias. All these factors were mentioned in the grade line for each outcome. There are about 14 PICOT questions in this guidelines, and we'll show you some tables where you can see them. If the evidence can be upgraded, if there is large consistent effect, dose response, confounders only reducing the size of effect, otherwise it is there. Now assign final grade high, moderate, low, or very low for the evidence. Then you consider other factors affecting recommendation, balance of desirable and undesirable effects, cost effectiveness, preferences of patients, and finally somebody may say, I would not like to take injections. I would like to take oral medication. So you have to consider that also into. Then finally you make a recommendation: strong for using, weak for using, strong against using, weak against using. So this is one, and this is so either recommendation is weak or strong. This is what you are going to see in the guideline. So the PICO questions that are given in this ESO guidelines are treatment with treatment within 4.5 hours of symptom onset. That is first question. Treatment, this most of you know that, but we'll see how it has been established in one or two trials. Treatment between 4.5 and 9 hours after known onset without use of advanced imaging. Treatment between 4.5 and 9 hours after known onset with the use of advanced imaging. Stroke on awakening from the sleep and unknown onset. So the sleep onset strokes, wake up strokes. Stroke on awakening from sleep and unknown onset. Tenectip plays, whether can be used in large vessel occlusion or not. Alternate doses, low dose altiplase, and adjunctive therapies, antithrombotic drugs and sonothrombolysis. What is their role? Higher age, multimorbidity, frailty, or prior disability. And what do we do in such a case, whether we give altiplase or not? Minor stroke, disabling, non-disabling. Strokes with rapidly improving neurological signs. Shall we do or shall we not do? That also we'll answer. Severe stroke. Today we had a severe stroke. Whether to treat or not to treat, there is a lot of confusion. So this particular guideline answers that question. High blood pressure. It can be controlled. It can be uncontrolled, and a patient may come with pre-stroke hypertension. High blood glucose level, hyperglycemia at stroke onset, and diabetes mellitus. Most of our critical care people and all, they are not mindful of the glucose level when they're treating. They are just giving few units of insulin to keep for the giving sake, but they are not seeing that should keep it between 140 to 180, right? Use of antithrombotic drugs before the stroke, like antiplatelets, vitamin K antagonists, NOVAX, and anticoagulation before stroke. So, what is their role and how we select patients? That's the 12th question. There are potential risk factors for bleeding, like low platelet count, recent trauma or surgery, history of ICH, microbleeds, white matter lesions, and cerebral aneurysms. They all will bother us whether to give a treatment or not. And lastly, other coexisting conditions like past history of stroke, history of seizures at onset, dissections, MI, and infective endocarditis. All these things we keep thinking, keep looking at them. Recently also, we had a case of infective endocarditis still in our ward and being treated. So first, treatment within 4.5 hours of symptom onset. You see, the number of studies which is there is about nine here, and the study design, randomized trial, risk of bias is not serious, inconsistency not serious, indirect not serious, imprecision not serious, other considerations are nil. Finally, when number of patients and effect size, you see 82 more per 1000. That means there is a confidence interval and high quality evidence is produced in this. This is I'm telling in detail. For one or two things we will discuss in detail. And treatment within 4.5 hours of the onset with acute ischemic stroke. Does intervention intravenous thrombolysis with alteplase lead to a better functional outcome than no intravenous thrombolysis? That's a five-card question. We saw that Delphi method has given the functional outcome is the most important thing which they are considering. So pooled odds ratios for excellent outcome. The patients receive MRS 0 to 1 in patients treated with IVT versus controls. In the 0 to 4.5 hours category, time window, the numbers and the odds ratios are depicted here. You see there is a favorable diamond towards the in the overall assessment. So we can give a recommendation for patients with acute ischemic stroke of less than 4.5 hours duration. We recommend intravenous thrombolysis with alteplase. Now you see the quality of evidence is high here, strength of recommendation is strong, and this is a very good situation for you all to understand that yes, this guideline is assessed completely. All the studies were studied. The risk of bias, inconsistency, imprecision, indirectness, and publication bias has been completely thoroughly assessed. So this is the recommendation. This is the quality of evidence. This is the question. This is the ESO guideline. Each guideline I will be dealing twice so that you understand better. This is the tabular form in in patients with acute ischemic stroke of less than 4.5 hours duration. Does iv-tPA will lead to better functional outcome than no iv-tPA? And what is the recommendation? We recommend the treatment with iTPA. That's the recommendation. So that's how all the questions were answered in these guidelines. The second question, suppose if a patient has come after 4.5 hours and treatment has to be started between 4.5 and 9 hours after the onset is known without use of advanced imaging. So that means you are not looking for diffusion perfusion mismatch or other things. Then what is the role of iv-tPA, whether we should give or not? This is by the from the extend ECAS and epithet trials. The time windows of 4.5 to 6 hours and 9 hours, and this has been studied extensively, and the forest plot is shown here, but the recommendation is no intravenous thrombolysis for this. In patients with acute ischemic stroke of 4.5 to 9 hours duration, known onset of time, and the selected only with plain CT, we should not thrombolize the patient. And so the quality of evidence is moderate, then recommendation is very strong. And again, this is shown in the tabular form, and you see there is no intervention for this type of situation. The third question is, after treatment between 4.5 and 9 hours after known onset with the use of advanced imaging. There it is clinical, it is advanced imaging. There it's only plain CT. The second point, here it is different. You see there are a number of studies, 3, and you again they have assessed the study design is randomized trials, and risk of bias is assessed, inconsistency, indirectness is assessed, there is imprecision in these studies, and there are other conditions, of course, are none. And finally, they gave to a conclusion. What is the conclusion? The quality of evidence, they say, is low because we have seen all that. The strength of recommendation is strong, but whatever is available for patients with ischemic stroke of 4.5 to 9 hours duration and with CT or MRI core perfusion mismatch, for whom mechanical thrombectomy is either not indicated or not planned, we should treat with TPA. So some parameters, automated processing software will be able to provide them in future. In fact, core volume less than 70, critically hyperperfusion volume divided by infarct volume more than 1.2. The mismatch volume is more than 10 ml. The cerebral blood flow less than 30% on CT perfusion. The ADC is 620 millimeters per square. Diffusion MRI. Tmax is more than 6 seconds. Perfusion CTR. Perfusion MRI. These are the radiological parameters over which we can base our decision. So this is again shown in a tabular form. The recommendation here, there are expert consensus statements also. You see that for patients with ischemic stroke of 4.5 to 9 hour duration with no CTR MRI core perfusion mismatch, what 9 out of 9 group members suggest against iv-tPA? But if you have that, if you have those parameters, they could not reach a consensus regarding whether IV thrombolysis should be used before mechanical thrombectomy or not. So there is a doubt here, and this doubt is still persisting. So whether iv-tPA should be used before mechanical thrombectomy or not, we are not very sure. Some people use it, some people you may not use it. Okay. So again, the parameters which I said. So one expert comment consult statement again we'll read. For patients presenting to a non-thrombectomy center, I mean there is no thrombectomy center, with ischemic stroke of 4.5 to 9 hour duration, this is a real pragmatic life situation with no onset, with CTR MRI perfusion mismatch, who are eligible for mechanical thrombectomy. 6 members suggest IV thrombolysis. So as far as I am concerned, if I have a diffusion flare mismatch more than 4 point last known well more than 4 hours, less than 4 hours, then we can see that we can give thrombolytic therapy. The fourth one is the most important, which we keep coming across, that is the wake up strokes and stroke on awakening from sleep and unknown onset. The lot of studies, the diffusion flare mismatch studies, wake up trial. So this is again a risk of bias is not very serious. That means acceptable. Inconsistency, indirectness, imprecision, not serious. So all these parameters will tell us that this is a high quality evidence that is being generated. This table is shown only to give you that idea. For patients with acute ischemic stroke on awakening from sleep who were last seen well more than 4.5 hours earlier, who have an MRI diffusion weighted and flare mismatch, for whom mechanical thrombectomy is either not indicated or not planned, we recommend the iv-tPA. And the quality of evidence is very high, strength of recommendation is very strong. There is a consensus statement for patients with acute ischemic stroke on awakening from sleep who have CT or MRA core perfusion mismatch within 9 hours from the midpoint of sleep, 9 hours from the midpoint of sleep, and for whom mechanical thrombectomy is either not indicated or not planned, iv-tPA should be given. That's what the expert comes. So there are two parameters now. We're extending the time window from 3 to 4.5 and 4.5 to 9 hours also for iv-tPA. So this is the one which I put it up in a tabular form, but same thing, the quality of evidence is very high and strength of recommendation is very strong. Right. Now, tenecteplase, and in patients with acute ischemic stroke of less than 4.5 hours duration, does IV thrombolysis with tenecteplase lead to better functional outcome than with alteplase? The number of studies you have seen are many, two at various outcomes have studied, and the functional outcome, the death, the ICH, all have been studied. The risk of bias is very serious in these all studies, and inconsistency though not very serious, but the risk of bias is very serious, and as a result you see wide and unfavorable confidence intervals which are crossing 0 or 1. So these results are inconsistent. So for patients with acute ischemic stroke of less than 4.5 hours duration not eligible for thrombectomy, we suggest that intravenous thrombolysis with alteplase over tenecteplase. So that issue is settled. So we will not treat with alteplase. So for the large vessel occlusion, it's a different scenario. What is the question which we asked here? In patients with acute ischemic stroke of less than 4.5 hours duration, with large vessel occlusion who are candidates for mechanical thrombectomy, for whom IV thrombolysis is considered before thrombectomy, which drug you use, tenecteplase or IV alteplase? So here the favorable result is for IV alteplase. So here the quality of evidence is low, recommendation is weak, but for patients with acute ischemic stroke of less than 4.5 hour duration with large vessel occlusion who are candidates for mechanical thrombectomy and for whom IV thrombolysis is considered before thrombectomy, it is suggested that IV alteplase or tenecteplase 0.25 milligram per kg over thrombolysis with alteplase 0.9 milligrams per kg is preferred. So that issue is settled now up to 4.5 hours. If you are planning for mechanical thrombectomy, we should use tenecteplase. And this is what is depicted in this tabular form. This is a recommendation, and this is the picot question which ESO guidelines have framed for this. Large vessel occlusion we have already studied. Now the alternative dose, whether thrombectomy, IV alteplase of low dose, whether we can use low dose. So in patients of ischemic stroke, does IV thrombolysis with low dose alteplase lead to non-inferior or not worse functional outcome compared to the standard dose alteplase? That is the picot question which has been studied. They recommend standard dose alteplase over low dose alteplase based on the high quality of evidence and strong. So there is no role for this one. The quality of evidence is high for the full dose. There is nothing like a low dose, though we would like to think that low dose may help us. So adjunctive therapies, it is antithrombotic agents and ultrasound. For patients with ischemic stroke of less than 4.5 hour duration, do you recommend any antithrombotic drugs within the 24 hours of IV thrombolysis? That question is answered. Uh, as an adjunctive therapy with alteplase, the answer is strictly this is no. It is not to be recommended, and you see the odds ratio and the wide confidence intervals. So for patients with acute ischemia, we recommend against ultrasound augmentation in patients receiving intravenous thrombolysis. This is based on the clot burst trial. The sonothrombolysis also is not recommended. So what do you say about the antithrombotic drugs? So for patients with acute ischemic stroke of less than 4.5 duration, we recommend no antithrombotic drugs within 24 hours of intravenous therapy. Uh, right? This quality is low, but recommendation is strong. The sonothrombolysis against thrombolysis, ultrasound augmentation in patients receiving iv-tPA. See, the quality of evidence is low, recommendation is strong, but so next is higher age, multi-morbidity, frailty, or prior disability. These are real life situations where we keep getting such strokes. Uh, does more than 80 years of age. Does iv-tPA lead to a better functional outcome? Is answered here, and it says it slightly. The results. This is not the one which we are going to see. It is recommended that thrombolysis should be given. My personal experience is that I have given up to 94 years of age. So 9 by 9 group members, this is a strong recommendation, believe that age alone should not be a limiting factor for IV thrombolysis, even in other situations covered in the present guideline, like wake-up strokes and ischemic stroke of 4.5 to 9 hours duration, with no onset time, with CTR MRI core perfusion mismatch, minor strokes with disabling symptoms. So, any type of stroke, age is not a bar. So, in patients with acute ischemic stroke who have multi-morbidity, frailty, or prior disability, what do? We we suggest that you give IV thrombolysis with alteplase, though evidence quality is very low and recommendation is weak, but you still can give with, with the understanding that the prognosis may be bad. Higher age, multi-morbidity, prior disability, we can give, but the quality of evidence is a bit low, but for age there is a high quality of evidence and a strong recommendation. So no age is a bar for giving this. For others, there is a problem. Minor stroke and stroke with rapidly improving neurological signs. What are we going to do about that? In patients with acute minor disabling ischemic stroke, which is of less than 4.5 hour duration, does iv-tPA lead to better functional outcome where than no IV? So what we do is, what the recommendation is, you have to give iv-tPA, minor disabling ischemic strokes. That quality of evidence is moderate and strong recommendation based on the studies of 9 studies, which are RCTs, and there is no risk of bias here. There is no inconsistency. Some indirectness is there, and imprecision is in one, it is there, and in the other it is there. There are some strong associations. So based on all this, we say that this evidence is moderate grade and the strength of recommendation is strong for using iv-tPA. Right, that's good. For non-disabling things, in patients with acute minor non-disabling ischemic strokes, with do we give or don't we give? That's the question. So there is no recommendation for iv-tPA in non-disabling. The disabling strokes of mild nature include aphasias and dexterity hands, if they are right-handed and they are doing fine works, then you should consider them as disabling. For non-disabling, for minor strokes, there is no evidence for IVT. So, for patients with stroke and rapidly improving neurological signs, still disabling, 8 of the 9 experts suggested IV-tPA with alteplase. The group agreed that treatment decision should be based on the clinical status and presentation, that it is not justifiable to wait for dissolution of symptoms. And so the answers are rapidly resolving symptoms. You have to give the treatment. Should be based on the clinical presentation. It's not justifiable to wait. So you give treatment with IV-tPA. So this is the minor disabling strokes, minor non-disabling strokes, and this is a rapidly improving symptoms. So the essence of this table is that we should give treatment, should not wait for this. Severity of the stroke. Whether if stroke is more than NHS 25, whether we should give or not has been studied in 9 randomized trials. with risk of bias is very serious, not inconsistency, indirectness, imprecision, other considerations. And what is the final nature, what we have done based on the favorable outcome studied in ECAS, NINS, and other trials? What is shown here is that the pooled odds ratio for favorable outcome in patients with ischemic stroke of less than 4.5 hour duration, that you should give iv-tPA, and you see the favors intravenous thrombolytic therapy. This diamond you can see, which is favorable based on all these trials, IST, NINS, ECAS, and they say that the this is favorable. So don't worry about severity of the stroke. You please give intravenous thrombolytic therapy, and uh, there is a vein of evidence that by the favorable outcome that is studied at 3 to 6 months, based on the handicap scale of Oxford and IST3 MRS scales. So they have got a good result. We have to consider and institute thrombolytic therapy. If it is not clinical severity and you are looking for radiological severity, then there is a problem. The early ischemic changes on baseline CT, there is a confusion here whether to give or not, and then severe stroke, what the consensus statement. So we have two issues. One is the clinical severity, others is radiological severity. For patients who clinically severe acute ischemic stroke of less than 4.5, we recommend IV thrombolysis. Good. For the radiological severity, and that is early changes on CT, that alteplase be considered in selected cases. In selected cases only you consider a young patient whom you think that is going to benefit. You give 7 out of 9 group members voted for iv-tPA in selected patients with severe stroke associated with extended radiological signs of infarction, like early ischemic change of more than one third of the MCA territory or aspects of less than 7 on plain CT. The patient selection criteria might include eligibility for alternate reperfusion strategies like mechanical thrombectomy and perfusion core mismatch, time since symptom onset, and pre-stroke disability. All these factors, all these factor into a decision making with this severe stroke treatment. So this is what is the severe stroke recommendation. About high blood pressure and high glucose levels, there are interesting things here. The if you are considering for IV thrombolysis, so the blood pressure should be less than 185 and less than 110. So blood pressure should be treated with persistently increased blood pressure above 185/100, even after blood pressure lowering treatment, then don't give. If you are able to bring it down, then you can give. So that means more than 185 by 110, even after treatment, persistently high, this is called uncontrolled, you please don't give. Controlled blood pressure, if it is you are able to bring down the blood pressure from 185 systolic and 110 diastolic below, then you can give intravenous thrombolytic therapy. This is controlled situation. Pre-stroke hypertension, an individual may have hypertension before getting a stroke, with that's called pre-stroke hypertension. There is no bar to give alteplase. High glucose level, patients with ischemic stroke of less than 4.5 duration with a blood glucose level of more than 400 milligrams, can you give iv-tPA or not? So what is the quality of evidence? Very low. Strength of recommendation, very weak, but it is suggested that you should give. And that means iv-tPA should not prevent the administration of insulin therapy in acute ischemic patients with high blood glucose levels. You start IV insulin and start, but hypoglycemia is a contraindication. Intravenous thrombolysis with alteplase in diabetes mellitus patients is recommended. There is no contraindication here. So these are the tabulated forms of the same question with recommendation and expert comments. So We understood the glucose and the recommendation for diabetes mellitus. Now we go on to the antithrombotic drugs before the stroke, and dual antiplatelets or single antiplatelets prior to the stroke. What do we do? Intravenous thrombolytic therapy, should we give or not give? So suggest is that we should give. The quality of evidence though is low, the strength of recommendation is strong, and even patients who are on single or dual antiplatelets, they develop stroke, we give treatment. Suppose if INR is less than 1.7, even when patients are oral uh, antagonists of then we can vitamin K antagonist, then we can still give treatment. If it is one more than 1.7, then the problem comes, and we recommend there is no intravenous thrombolytic therapy if it is more than 1.7 of INR. So that's but the quality of evidence is very low, but the strength of recommendation is strong as we have upgraded the evidence here. So, what about what are the other things which we have to the study about anticoagulation, that is NOVAX before stroke, and what is the what do where do we stand? So during last 48 hours before the stroke onset, there is no specific coagulation test available. We should not give any thrombolysis. That means uh, a patient had a stroke and he has taken dabigatran, rivaroxaban, apixaban, endoxaban within 48 hours before the onset of the stroke, and we don't have any facility of lab facility, then we should not thrombolyze that patient unless you have some specific factors where you can do the testing. Then you can suggest IV thrombolysis with reversal of the effect of the drug. More than 48 hours lapsed, you can give a recommendation to treat this. So reversal can be attempted with idarucizumab, and then you can give intravenous thrombolysis therapy if you have less than within 48 hours. So this is an important guideline which has emerged for patients with ischemic stroke who use factor 10A inhibitors during the last 48 hours before the stroke onset. The experts felt that combination of endexanet and iv-tPA with alteplase over no iv-tPA is preferred. That's the recommendation, expert recommendation. So this is again tabulated VKA, vitamin K antagonist, Novax, which we have read. The potential risk factors for bleeding, very important aspects here. Low platelet count. So if the platelet count is less than 1 lakh, we suggest no IV thrombolysis. That's what is the consensus statement. And unknown platelet count before initiation of IV and no reason to expect abnormal values, don't hesitate in giving thrombolytic therapy. Quality of evidence is very low, but strong recommendation for this. We have upgraded that. Potential risk factor for bleeding, like a recent trauma or surgery. So, what is the recommendation? During the preceding 14 days, if there is a non-compressible site surgery where bleeding is likely to lead to significant hemorrhage, that is abdomen, chest, skull, well vascularized tissues, a large artery. There is no thrombolysis. 14 days, no thrombolysis, major surgery. That's the recommendation. What happens in an individual who has got a past history of ICH, intracranial hemorrhage? Can we give? And here it is a expert recommendation. 8 out of 9 members suggested IV thrombolysis in selected cases. I mean, what are the selection cases? A long time has elapsed. If there was a specific underlying cause for the hemorrhage, like trauma, cerebral hemorrhage, endovascular or surgical aneurysm removal, use of specific anti-thrombotic medications, etc., then you can consider giving. But that what is a long time lapse, we really don't know that how much time it is. So that's a risky proposition. So suppose if there are microbleeds, what will you do? We have cerebral microbleeds. If the microbleeds are less than 10, we suggest IV thrombolysis to alteplase. And if it is burden is high, then no alteplase. That's the important thing. But do you have to do an MRI to see whether they got microbleeds or not? The recommendation is we should not there is no role for screening MRI before RTPA to assess the microbleed burden. That's an important issue. So white matter lesions also we keep seeing them, but there are about four studies of randomized trials who have studied about functional outcome at 3 to 6 months. So their inconsistency is not serious, risk of bias is not serious, but there is indirectness which is very serious, and imprecision is not serious. So the evidence that is generated will be good in this. So for patients with acute ischemic stroke of less than 4.5 hour duration, small to moderate burden of white matter lesions, we can give altiplase. But if the burden of white matter lesions is more, then the we suggest uh, it's a suggestion that be careful what you give, but there is a problem, there may be problems, so it's only suggestion. Here it is a recommendation, here it is only a suggestion. So you see the difference between them, you read in between the lines. Cerebral aneurysms, so what is the role? Who have unruptured cerebral artery aneurysm, there is no contraindication for active placement. You can give. So quality of evidence is very low and strength of recommendation also weak. This is what it is. Low platelet count. We have already said recent trauma or surgery, history of ICH. See ICH again, we are not very sure when to give, and microbleeds we have seen that uh, less than 10 and more than 10. And of course white matter lesions, the lesion burden if it is more, and that it is only suggested that you can give but not recommendation. Its burden is a little small, then you can certainly give, right? Cerebral aneurysms, unruptured cerebral aneurysm, no contraindication, you can give the treatment. Other coexisting conditions like a stroke, history of stroke, in the last 3 months, 9 of the 9 members voted for IVT with altiplase in selected cases. For example, if the case of the small infarct, stroke occurring more than 1 month earlier, and good clinical recovery, so you can consider. So the time frame, that is the last 3 months, if you are thinking whether to give or not to give, the factor, these are the deciding factors for that. And the quality of evidence is very low, but the strength of recommendation is also very low. Now whether a patient has a seizure at the onset, so at the stroke onset, there is no suspicion of a stroke mimic or significant trauma, then we should give multiplies. That's an important thing to understand. Dissections. What do we do about dissections? And dissections also, we have three types of dissections. One is if your aortic arch dissection, what will you do? We recommend no iv-tPA. If it is a cervical carotid artery, you can give, but the recommendation is weak. For intracerebral artery, suggest against. That means the dissection allowed is only carotid artery, not the arch of aorta, not intracerebral. Mind you, that's important. What is the recommendation for MI? Again, we have three categories of MI here, and more than if it is last 7 days, there is an MI. No, there is no IV thrombolytic therapy. If it is a history of MI during the last 3 months, you can give, not 7 days. So between 7 and 3 months, you can consider by the size of the MI whether recanalization therapy was given for MI and echocardiography findings. So you have got category 7 days, 7 days to 3 months, and beyond 3 months. Beyond 3 months, there is no doubt. 7 days to 3 months, we have to decide by the size of the MI and whether recanalization therapy was given or not, and echocardiography findings. And less than, if an MI is happened within 7 days, there is no role for doing this. There is no role for iv-tPA. Okay, so that's it. Right, nice, nice. Okay, important. Infective endocarditis. We have one case of infective endocarditis where we have been managing now. What is the recommendation? There is no IV thrombolysis. So in patients with acute ischemic stroke of less than 4.5 duration, the clear or suspected diagnosis of infective endocarditis, which suggests no IV thrombolysis. The quality of evidence now is low, strength of recommendation is strong. That's important. And this is again tabulated history of stroke, seizure, dissection, myocardial infarction, infective endocarditis. That brings us to the end of our talk on the guidelines, and which we have tried covering and studied about great system of evaluation also, and the stroke guidelines. So that's good. And any question from anybody you can ask. Vikram, how is it? Did you understand? Are you there, Vikram? You can unmute. Yeah. Okay. So if there are no questions, then I think I'll end here and end the meeting.